All right. I will go ahead and get us started. Thank you everyone so much for joining us today for our International Children's Day event discussing a rights-based approach to child health. As a reminder, this program is being recorded. Please feel free to post any questions you have in the chat. If you're having any difficulties with Zoom, please message me for assistance. My name is Taylor Lees, and I am a second-year maternal and child health MPH student. It is my pleasure today to introduce Chinenyanwa Ilail, a first-year MPH MCH student who will be moderating this event. Before we get started, we want to take a moment to acknowledge the lands that we are on today. While we are gathered virtually, it is important to acknowledge that our institution is situated on the traditional, ancestral, and contemporary lands of the Dakota people. We're taking this moment to consider their histories, languages, and cultures, and invite you to do the same wherever you're joining from. A link will be shared in the chat that will allow you to identify the land that you are currently on. We'll put that in there right now. All right, and now I will pass it on to Chinenyanwa and our wonderful panelists.
Thank you so much, Taylor. I'm so excited about today's discussion. Really, it's a great privilege to be seated in the same room with our three amazing panelists. Without taking more time, I will go into our main topic for today. If you don't mind, could you all introduce yourselves, your current work with children and youth, and how you protect children's rights within your work? Dr. Laurel, do you want to go first?
Sure. I'm Laurel Cederberg. I'm a pediatrician at HealthPartners, Como Clinic. I am a pediatrician. I've been a pediatrician there for 25 years, and I also see babies at Regents Hospital. So I start the day that they're born. When we see them in the hospital, we're advocating for those babies' rights, because many times parents are excited to get home, they want to get going, but the baby's not ready to go home all the time. Sometimes the OBs say, hey, you can go home, mom, at 24 hours, you're fine. But it's saying, hey, wait. I'm always saying, wait for the baby. We have to check the baby's jaundice level to make sure that the baby's not going to have problems with jaundice. We have to check sometimes the mom's blood type to make sure that there's not going to be a problem. If babies are born early or this kind of late term early, we try to make their experience as normal as possible, but people have this idea that they can go home right away. And so many times we're advocating for the baby to try to get breastfeeding going. We're looking at those metabolic screens, on and on, all that screening that we do there. In the clinic, I'm advocating for kids all the time with vaccinations, discussing that in collaboration with their parents on why we want to do them now, that education so they can make those decisions for their kids. So we want people to have the rights to those vaccines. As kids get older, they are dealing with mental health issues. And so we're always trying to explain to children that they have those rights to counseling. They have that right to medication. Teens and young adults, that they have the right to that. And sometimes families don't feel comfortable with that. And so sometimes that's when you're really trying to get that education to say that's really in the best interest. So those are just a kind of a little bit, and education and opportunity for teens to have that time, that right with their provider, to have that one-on-one time without their parent there, to learn to advocate for themselves and to take care of themselves. So just a brief look.
Thank you so much, Dr. Laurel. Thank you so much for sharing that with us. Dr. Michelle, would you want to go?
Yes, good evening, everybody. It's a lot later in South Africa than it is in your part of the world. I'm a pediatrician based in Cape Town, South Africa, and I wear two hats here. I'm the director of an NGO called Paedspal, and Paedspal is a multidisciplinary team consisting of doctors, nurses, social workers, therapists that provides a pediatric palliative care service to children at the Red Cross War Memorial Children's Hospital in Cape Town. And then in my other job, I actually lecture on the postgraduate diploma in pediatric palliative medicine at the University of Cape Town. So our job is very much meeting the rights of the child with non-curable illnesses, so the child with life-limiting or life-threatening illness, to actually live up to their full potential. You know, I think often we think about, when we think about palliative care, a lot of people think about children that are dying. And yes, that is an important part of our work, but it's really actually a small part of it. A lot more of palliative care is actually focused on actually maintaining the best quality of life for as long as possible. And I like to speak about inalienable rights. You know, it's a right that every child has, we have a duty to preserve. So the child has a right to be free from torture, to be free from pain. The child has a right, even though the child is very sick, to participate in school activities, to play, has a right to be a child. You know, a lot of these kids have very serious conditions, and, you know, they kind of forced to grow up as soon as possible. And we sometimes forget that they are children. So that's something else that we also protect. They also have a right to a family. And sadly, sometimes if, you know, they've got a chronic illness that requires, you know, a heavy burden of care upon the family, they may end up being institutionalized. And that's really something that we'd like to try and avoid at all costs. So yeah, I think we really do work very hard to ensure the right of the child with a chronic life-threatening condition to the best quality of life for as long as possible. And then when the time comes and when death is inevitable, the right to a good death and with family around them.
Wow, thank you so much, Dr. Michelle. It's really good to see you again. I had a great, I really had a great learning experience working as a volunteer at your organization, Paedspal, you know, during my study program at the University of Cape Town in South Africa. It was a great privilege to work with devoted team and constantly advocate for our children's needs and rights. Thank you once again for being here. Erica, do you want to go?
Yeah, hi all. What a treat to get to hear what you both do. So I'm Erica Koepsel. I'm the Patch Program Implementation Director. I am based out of Madison, Wisconsin. And so Patch stands for Providers and Teens Communicating for Health. And we have several Patch sites that are both in and outside of Wisconsin, where we hire and work alongside teens actually. And we work in their community to improve adolescent health and healthcare experiences. So specifically, the teen educators that I work with deliver workshops to other teens to help them better understand their rights in healthcare and empower them to start taking some responsibility for healthcare, because they do have those rights and they can feel more comfortable and confident in that. They also lead workshops with healthcare providers, pediatricians, family medicine folks, really anyone that might be providing them any kind of health and healthcare. And really the goal there is that providers can hear directly from young people about the needs and concerns when it comes to health and healthcare. And a lot of that, as you can imagine, directly relates to communicating about, maintaining, and advocating for confidentiality and adolescent rights in healthcare. That one-on-one time is a big part of it. We do also have statewide teams of youth advocates in Wisconsin who are also consulting on different adolescent health-related projects so that they're improving resources and access to services for young people, because we know having those youth voices involved is really beneficial for making sure their rights are respected in that. I will also say, so my perspective on this, I help coach other adults who are leading Patch sites. And every year for the past 6 years, I've had the privilege of hiring and working closely with a group of 10 to 13 teen educators in the Patch Madison area. They're all high school students hired from the city of Madison or the surrounding communities. And so a lot of my work and my perspective and my organization's work is very directly related to the experiences of teens. So that's what I'm bringing today. And specifically that timing of transition from adolescent to adult-based care. We know teens and young adults often get lost in that process. Their rights are often overshadowed as teens, and then they don't really understand them when they become of legal age to consent to care on their own. And so we try to prevent that as much as we can and bring youth along for the ride. So I'm excited to be here with you all and chat more about it.
Thank you all so much for sharing that. It is so interesting to learn about the great work that you all do to protect the rights of our children at your practice. Thank you so much. The thought of having a health condition that cannot be cured has a long-term impact on children's general well-being. Many healthcare professionals are ignorant about the needs of these children. And often children, youths, adolescents with special health care needs or disabilities are forgotten in conversations surrounding decision-making. Our question is, what roles do providers play in ensuring that the rights of those with disabilities are respected? How can healthcare system adapt via evidence-based practice and advocacy to fulfill the special needs of these children and their families? Dr. Laurel, would you want to go?
Sure, yes. This is one area where I've worked early on in trying to build the tools to make this evidence-based. I worked in 2014, 2015 as part of one of 5 Minnesota sites where we got a grant from MDH and Family Voices of Minnesota, led by CC Chaplin at the time. And we were one of 5 sites, HealthPartners, Duluth, HCMC, St. Cloud, 4 sites, excuse me. And we helped the GOT transition from the National GOT transition. We tested their tools, the questionnaires for readiness for transition of youth and young adults with chronic issues. We developed within our system ways to monitor this, to get the information to providers, to bring up the discussions about that transition, whether that transition would be from pediatrician, your pediatric care, to an adult provider, or that natural transition from that relationship in your family practice or general practitioner, where it goes from your relationships as a child with the same person when you're now adult, and getting those kids ready. So trying to get them to call for their appointments. Unfortunately, we didn't have a medical record where the kids had a right to get into to make their appointments, but I wanted to encourage them to learn about their medications, learn where would they go if there was an emergency based on their condition or any kid, to learn how to advocate for themselves, learn about their medications. So that became a big part of our practice. We actually got in the kind of the smart set or the computerized thing, readiness. And then we had a drop down that we had discussed these different things. That transition, that smooth transition, if you're going to transition from a pediatric provider to an adult provider, getting all that information ready for that transition so that it would be smoothly done. So that was one of those projects that we helped out back in the 2014, 2015.
Thank you so much, Dr. Laurel. Dr. Michelle?
Yes, I think coming from a low middle income country, often the kind of, most paramount right is the right to life and the right to health. And I think a lot of our focus has been on actually getting children to survive. And the problem that we find in these kind of settings is our health system is really geared towards acute care. So if you have an acute illness, we will look after you very well. But if you have a chronic illness, and especially a non-curable illness, unfortunately, in a big, busy system, these are the kind of children and family that actually get lost. And sadly, a lot of families are told, I'm sorry, but there's nothing more that we can do. And what we usually mean when we say this is that from a curative perspective, there's nothing more that can be done. But in palliative care, we always say there's never nothing that can be done. Even if you have something that's not curable, there's still a lot that needs to actually be done. And, I think a lot of the times in busy practices as well, everybody's focusing on the bioclinical aspects of care, and they kind of forget the psychosocial and the spiritual and the siblings and the rest of the family, And actually most health happens in the community, not in the hospital. So I think the big lesson that we have to learn is actually how to provide a continuum of care that also mobilizes existing resources and looks at that child in the context of the family and the community. They always say, I don't know if this is an African saying, it takes a village to raise a child. So I think for a chronically ill child, it probably takes a whole city, and I have, tremendous respect for mothers who look after children with a high burden of care for long periods of time, and we really do need to rally more support around them. And, that child, even that child has limited capacity. They have a right to achieve their fullest potential. And we really need to work harder, I think, and think more out of the box in terms of how do we maximize their quality of life. And I think when it comes to the child themselves, often, especially children with disabilities, become almost invisible children. And I think we don't engage sufficiently with them, and we don't involve them enough in decision making. And I think that really is something that we need to do. Even if their level of understanding is not, at the full level, we really need to still engage them. And even if they don't have to give consent for something, they still need to be assented, and they need to be part of that place. And just one more thing, I think, often the sibling of a child with a chronic illness is forgotten. With all the focus on that child, they get forgotten. And of course, they try not to complain because they can see that mommy and daddy are very busy with a sick child. And I think we often forget about their right to education and their right to play and also to develop to their full capacity.
I'd just like to say that Minnesota's Family Voices, I was wearing a pin that they had that 1 in 5 children in Minnesota have some sort of disability. And so that really focuses on the amount of care that we are giving to those kids and the importance of taking care of those kids in multiple situations, whether it's in the primary care clinic with specialists. And I agree with everything you said in taking care of those kids. And it is that community, that is a community-based group here where it's parents to parents, peer to peer. If you have a new baby with a certain condition, then they have parents who are willing to talk to other parents to help them through that initial point and bring them through. So here, yeah.
Thank you so much, Dr. Laurel and Dr. Michelle. That's what actually stuck in my head when you said that it takes a community to raise a child. And, we need to see the child with the lens of, the context of the family and the community. Thank you so much for that. Erica, do you want to share with us?
Yeah, I love the thoughts coming around, like the transition checklists are so great, getting you to start kind of seeing what steps they can take, this idea of the way we treat acute illness versus chronic illness. And honestly, a lot of the work I do with teens, I think the first part for having providers connect and provide autonomy to youth with disabilities is actually checking our own assumptions as people working with those young people. And I think part of that means starting with a belief that that young person has perhaps a higher threshold for independence than providers, parents, or other caregivers initially think. So often the assumption is that they don't. I think you were even saying that, Dr. Michelle, that we don't give them some of that independence and those abilities to participate in decision-making. And so I think we work with a lot of youth, some who have complex healthcare needs and some who do not. And having that opportunity for one-on-one time, for confidential conversations, it's still really, really important. And if it is found that there are more supports that are needed, which we know there often are, it is so much easier to bring those supports back in rather than turn control over to teens after a parent, guardian, or someone else has been doing it for years for them. We have a teen right now a wonderful teen who does have some complex challenges, and in just the few months I've known them, they've been really expressing frustration that for years they've been treated as a child. They've been spoken to like a baby, and they've ultimately not been addressed directly as people are addressing their parent or guardian because they don't think that she can do it because of her disability, or at least that's the message she's getting directly from several providers. And she also really loves some of her providers, but that's like a real message for her. And we've had another young person right now that we're working with who has a physical chronic disability. It's required them to go through PT for really throughout their life. And is also certainly now realizing and expressing that they weren't ever being asked for consent to touch their body. And she even mentions as a young person saying, like, why don't you have to ask me? Why do you just get to touch me? A provider told her it didn't matter because the parent or guardian had already consented and wasn't having that conversation. And so obviously the lack of autonomy, it is harming their trust in the system. It's harming their understanding of healthcare and their ability to find their threshold for what they can and cannot control or consent to, and how they can partner with parents and guardians, I think, within that. I do think the healthcare system makes it hard for healthcare providers, right? There's very limited time. There's a lot that has to do. We tend to take a universal approach for young people, which then doesn't meet unique needs. So I do think providers can advocate within the healthcare systems, potentially these longer appointment times, creating options for there to be medical chaperones that are not parents or guardians, so that youth with disabilities or complex healthcare needs can be honest about what they're doing and not feel like potential shame, because we know they're engaging in behaviors that teens, regardless of disability or ability status, are. And I also will say, I think a lot of work has to happen in adult spaces. We know a lot of youth, like we talk so much to pediatrics and family medicine, but when young people are transitioning and kind of being kicked out of that children's hospital vibe, it gets harder and harder to navigate and far less welcoming, and people are less excited to see you there sometimes. So making sure that we're on either side of that bridge doing the work, I think can be really important for making the system work for them, while providing them some decision-making opportunities.
Wow, thank you so much, Erica. I was just taking notes, and I noted some of the things that you said about checking our assumptions, and to understand that these teens actually deserve to have their independence and to have the opportunity to participate in decision making as regards to their health. Thank you so much for sharing that. Okay, so I'm going to move on to the next question. There can be a lot of tension when the desires of parents, caregivers, and guardians do not match that of a child. We can see that tension in access to sexual and reproductive health care, mental health care, education, vaccine uptake, and pain management for palliative care in youth. How can we further protect children's rights in these spaces? Dr. Laurel, would you want to go again?
Yeah. The thing is you want to, from an early age, have that set up in the visits that you're always there for the kid and the parents and you as a trio. So I always talk to the kids, no matter what first. I think that's interesting, just in reflection of what I do. Sometimes I've had an interpreter say, the mom is the one making it. It's like, no, I'm talking to the kid. I once had an interpreter mention that. It's like, no. And so I think it's really important that we're as that team of the three parties or whoever it is, and thinking about vaccines. There are parents who choose to not vaccinate for a certain reason. At some point, the kids may want to have that vaccine and decide that they're going to do it, or they might, for example, for the HPV, they might wait until they're 19 and then get that vaccine themselves if they don't have that discussion or want to confront their parents. We're in our practice very open to, if you don't want to do the MMR, why is that? We feel it's important. I'm saying every time, hey, if there's a measles outbreak, I want you in here for that nurse visit to get that MMR. Because I don't want to just say, oh, you don't want to do the MMR. Okay, like that's okay. It's not okay. Every visit we're asking, do you want to get that MMR, or do you want to get that whatever vaccine that you haven't gotten? So we always want to be there, give them information, discuss why. Is it time to discuss? And I have one mom who has not vaccinated anything, and she always says, thank you for asking, thank you for asking, thank you for asking. And so hopefully, there will be some information, or there'll be a time when that child can advocate for themselves that they do want to do it, or we're faced with a pandemic and we learn a lot about vaccine benefits. I will just say about sexual and reproductive care, that is a difficult one with parents. And I don't know, Erica, if you're going to talk about that as well, but that is an area where we really have difficulties trying to be open about those needs, asking the parents to leave the room. Is there any issues, and bringing it up at that time, or informing that you could come back by yourself, or there are conditions whereby you might have birth control pills if you have serious cramping or those types of things. So just educating on those options for those services. And services outside where it would be confidential, through a school clinic or through a community clinic where parents don't have the insurance and can look at the estimates of benefits, the EOBs.
Thank you so much, Dr. Laurel. It shows to know that we have a lot of work to do as healthcare practitioners and public health practitioners to keep educating the parents on the importance of vaccinating their children. Like you noted, most parents are being vaccine hesitant, and we need to just keep educating them and understanding, the reasons behind what are their fears and what are their concerns, and, educate them about the importance of vaccination. Thank you so much for that. Dr. Michelle, do you want to answer?
So, often I think when we think of autonomy, we think that the child has to have capacity, in order to make decisions. So I like to lecture about dignity. And dignity respects the individual rights of that child, irrespective of age and irrespective of whether or not that child has his own autonomy to make decisions. And sometimes dignity is a big fancy word, but it actually speaks to very basic things. Like if you are examining a very young baby, you don't unnecessarily expose that child. I think often hospitals are quite undignified places, and I think somebody spoke earlier about, people just rush in and do examinations, and they think because the child is very young, they don't have to ask permission. And that's actually not respecting the dignity of that particular child. And I think also one of the big things that often arises in palliative care is sometimes the child has a different view to which treatment is or isn't acceptable to that of his or her parent. And, even the child's spiritual or cultural or religious beliefs may be different from that of the parent. And sometimes we just make the assumption that it's the same. So really in palliative care, we always say, you need to actually, especially in our older children, have a separate consultation with their child, apart from these parents, because often children are also wanting to please their parents and, they're wanting to conform, and then you actually never really get to know them and what their individual needs are. So, we really also are very strong advocates for, as much as possible engaging that child on her own, so that you respect their individual autonomy and their dignity.
Thank you so much, Dr. It just reminded me on the same thing Erica said. She said we shouldn't make assumptions, and you said the same thing. And we shouldn't make assumptions on what we think the views and perspectives of these children are, and just assuming that it would be the same with the parents as well. So we have to respect a child's dignity. Thank you so much. Erica, do you want to add on that?
Yeah, I think some of mine might be repetitive, but recognizing this, that teens do indeed have healthcare rights. Again, from the teen perspective, even young people, right? That dignity, those abilities to be involved. Explain healthcare rights to confidentiality, what one-on-one time is, what consent to care is for youth, as well as their parents and guardians. Start with that group dynamics and make sure everybody's on the same page. Help them understand why it exists and frame it as a way for youth to start taking responsibility for their healthcare. They have to someday, many of them in some way, shape, or form. And we've found that if parents know earlier, especially parents or guardians know earlier, there's at least some understanding of that piece of it. Second, let youth know they have options, that they can consent to care on their own without a parent or guardian. In some cases, reproductive care is a big one. Letting them decide if your clinic is the place they should be seeking care, or if there's somewhere else in your community, like Dr. Lowe was already saying, public health department, Title 10 clinic, where they can get that care in a way that is super confidential for them, if that's what they need. I think first and foremost, at least from our organization and my perspective, we want them to get the care they need and deserve. And then sometimes that means there might be other things happening at home that we have to navigate, but making sure that they're healthy and engaging in preventive care is huge. And it might mean that you're not the one providing care, but you're directing them to those other services. I think too, as youth age, remembering that they are your patients and it's not their parent or guardians, listening to their concerns, their interests, help them navigate. I know so many young people want to engage in some of these conversations with parents or guardians, but really, really need support. They don't know how to bring it up. So, during one-on-one time, if you learn that a young person wants to get on birth control for any number of reasons, or is interested in getting a vaccination that their parent or guardian might not, I think that you can be one who can help them navigate that conversation and bring it up without the teen having to be the person that confronts a parent or guardian in a way that feels scary. I know also it's worth acknowledging, I think you said it, Dr. Laurel, you and the youth are not always going to convince or change the parent's mind. So also letting the youth know that there will come a time, often, 18 or 19, that there are ways, prepare them with the skills and knowledge they need so that if it can't happen when they are no longer, or when they are not allowed to consent to their own care, that they can work their way there, they can get there, and that they're having great conversations and asking great questions. The other two things I think are one big thing that is maybe external of the one-on-one facing time is advocate for developmentally appropriate laws in your community that could help youth begin taking control of their healthcare. Laws, including even vaccination laws, vary drastically from state to state. Some places youth can consent to vaccines, and that is not the case here in any way, shape, or form. And maybe it should be. Like, maybe we should be exploring those options for what youth can and cannot consent to care, and make sure they're developmentally appropriate for them. And hearing from professionals on that is huge. And I guess the last thing, just like respect teens' privacy. Start from the beginning, show them you care, maintain confidentiality. I think that's the more they trust you, the more likely they'll be to have these conversations with you and to have you come join them in the conversation with their parents or guardians.
Thank you so much for that. I noted all the rights to confidentiality, the right to dignity, the right to participate in decision making. Thank you so much. So we'll move on to the next question. There is profound evidence that both racial and socioeconomic disparities exist in the United States healthcare system, as well as internationally. In terms of child health, well-being, and development, how can we adopt a holistic approach to child health with consideration to children's context, culture, and evolving capacities in public health from a life cost perspective? Dr. Laurel, can you go?
I'm going to start again with babies. We have big disparities in birth weights and whether or not a baby is born early in this state, where we have African-American Black babies born at higher rates there. And this is due to those social determinants of health I'm learning in my classes here. It's not necessarily race or ethnicity, that's what we measure, but it's a social construct. And the real true causes that I'm learning are those issues of housing insecurity, food insecurity, structural racism, the stress of going out and what's going to happen to me, my child, my family. Those things put stress on a pregnant woman, and then that has complications for the baby. And so I work at Regions Nursery, and I'm taking care of the baby. I have not been involved in that prenatal care as much, but it's like it's disturbing to see those numbers across the United States and here, and we need to really work on those in a bigger picture, those social determinants of health. Now, can we, at that age, I'm going to go back to get more breastfeeding initiation? Can we increase those rates? Regions Hospital happens to be a baby-friendly hospital with it has the certification for positive encouragement of breastfeeding and education if you're going to do formula feeding. But we really need to get that early on because it has a great impact on the life course. If you're breastfed, we know there's many markers there that there are health improvements due to breastfeeding. And so having then those social determinants of health, access to care, coming in for those baby visits and not feeling that, I don't have coverage. And then being welcomed in that clinic, that we have diverse staff, we have diverse experiences, and that cultural humility. I have learned about cultural humility in my class, but I realized I learned it in residency. I did my residency at Oakland Children's Hospital in California. I went to the University of Minnesota Medical School, and I did my residency in California. And that was a great impact on my perspective of community and medical care and how it can be. I've also lived abroad. I lived in Sweden with my husband. I know what it's like to be an immigrant. I know what it's like not to know how to get things and need help. And I had a group of mothers. I had my first child in Sweden. And that group of mothers, we started meeting for the 2-week visit, the 2-month visit, the 4, 6. We were together doing that and having our anticipatory guidance together. And they were my group. Here in the United States, we tried to do group visits, kind of visiting based on the centering. I think there's a program for centering for mothers, doing that community support. And so I think it started in Massachusetts, where you have mothers starting. It would be ideal if that could continue with their pediatric group. It was hard to keep because of different people's not having maternity leave. Here in Sweden, we got a year of maternity leave, a year. We can go to our visits. We were focusing on those kids. Here, parents would come for the 2 months, the 4 months, but then they had to go back to work. And so this model didn't work. But I think that building community and addressing those social determinants of health and having good access.
Thank you so much, Dr. Laurel. Dr. Michelle?
I must say that's a very difficult question from a South African perspective. You know, unfortunately, South Africa is one of the countries in the world with one of the highest Gini coefficients. So we've got a big gap between our rich and poor. And we don't have national health insurance. And unfortunately, you know, the private sector takes up a lot of resources, but it's available to the minority of South Africans. And that's sometimes really difficult, you know. And sometimes decisions are made based on geography and based on, you know, the family that the child was born into. And, you know, we often have to fight for the rights of those children as well. I'd also like to pick up on something that Laurel said. I really love your concept of cultural humility. I think that's lovely. And, you know, we often have quite different sort of spiritual beliefs, even beliefs on the cause of illness. And we really need to respect that. And I've certainly learned a lot about that in palliative care. You know, it's interesting, if you think about a non-curable illness, people have different theories. And we actually need to respect the right of the family to, and we need to practice medicine in a culturally sensitive way, you know. So if the family believes that that child is ill because of bewitchment or something that happened in the ancestry, we actually need to provide opportunities for the family to address that. And we've certainly learned when following up these families in their bereavement journey, if you don't address those kind of things before the child dies, it actually has a significant impact on that family for the rest of, you know, their lives. So we really need to be more culturally sensitive. And I think, you know, even we need to look at our attitudes and examine, you know, do we actually treat different people based on their socioeconomic stage, or if their cultural or their racial identity is different from ours? Do we treat them differently? Are we really giving people the same care and respect across the board? And I think that's an important challenge for all of us as healthcare providers.
Thank you so much, Dr. Michelle. Erica?
Yeah, I think building off of what Dr. Michelle was just saying about this, like checking ourselves, are we treating people differently? I think a lot of it, from at least my work with teens, they've been like, check your biases, like, and check them over and over again. Make sure you're not changing how you interact with me, or at least don't let me perceive it either. Like, think about how I'm perceiving it, even if you don't feel like you're changing it. I actually was just in a room doing a peer-to-peer workshop with one of our youth of color the other day. And in his conversation with other youth of color in the workshop, he indicated that he felt like providers were more likely, in his words, and more likely to snitch on them because as a Black male, he was perceived to be doing something wrong, even if it was the same thing his like other white counterpart youth were doing. And I cannot tell you how many times, especially around race and socioeconomic status, I've seen youth in the peer-to-peer session express distrust in the system, and how many of them have said that it kind of failed them because a parent or guardian found out and they didn't think they would. And it really proportionally seems to be happening to youth who are also very underserved in our communities. And so I think being aware of those things and when they're happening and maybe why they're happening in your own practices, if you notice those trends, obviously the awareness of access to care barriers, transportation, housing, food sources, insurance, even clinic hours, especially for young people. You know, are their parents or guardians working during that time? Are they in schools? Is there other reasons they can't get to you? And do what you can to be more accessible. What are ways that you can adapt rather than asking the people who are coming to see you to adapt to that? And obviously consider those organizational partnerships. There's so many people doing great work in many of our communities. How can they provide transportation vouchers? How can you partner with schools, school-based health clinics, or how, you know, we have here school nurses that will actually connect with public health to get STI test results to the teen in the school because they can't access the teen clinic hours. And just how do you partner for that? I think another one that is really hitting many of the youth in our youth advocacy fellowship is how insurance impacts access to care, which we know, but the part that I'm finding new and interesting is we know that ACA like touts that youth up to the age of 26 can stay on parent insurance. Here in the US, you know, if their parents have insurance, it doesn't access, like some of the most vulnerable folks are not able to access that benefit if they're on Medicaid, and they will likely need to apply earlier and maintain their own insurance at a much earlier age without the structure to help them do that. It can leave a lot of young folks uncovered in their health world. And like I said, a lot of our youth advocates are facing that exact challenge for how do they do that, even though they're still technically teens. They're 18 and 19 and 20 and trying to navigate that. And so I guess if you do also notice a gap, check those assumptions again. Don't assume you know why there's a gap in their care. Talk with them, right? Ask them what's happening in their life. Is it that their maternity leave ended and they're no longer showing up, like Dr. Laurel was talking about? Is it they've moved and they no longer get the mail or the reminders or new phone numbers or whatever? Because I think those assumptions when you're like, oh, you must have had a gap in insurance. They're like, no, actually, there was a million other things going on, can be really harmful. And so a lot of our work is actually developing wraparound resources, connecting youth with a warm handoff. Where are the free and reduced care clinics? Where are the youth specific practitioners? Where are the topic specific support groups? Who can help them navigate insurance systems? I think being willing to find that community base is really what it comes down to, that you all were saying, is doesn't just have to be in the health system. It can be all these other places that they can get support, and how we build care teams to do that, I think, can be really huge.
Wow, thank you so much. It's really interesting hearing, the three of your perspectives. And I have noted here, all that you have said in terms of, being culturally sensitive, and also building that community, you all stated, understanding the child's context, where the cultural values, the religious values, what are the historical, the context, and being aware, being sensitive and knowledgeable about these issues would help us to be able to address some of their concerns. And thank you so much for sharing all of that. We would move on to the next question. Before we transition into our Q&A, actually, we have one last question as a takeaway, more like a call to action for our audience. So as a public health and healthcare practitioner, how can we participate in advocacy for policy change and empower children to participate in their healthcare and become self-advocates? Erica, do you want to go?
Sure, switching it up. Yeah, I'll go. I think there's a couple places that I have ideas. One is to advocate for change in your own healthcare institution. Certainly big policy is great, but we maybe have more control and leverage in the places that we're working. So prioritize practices that benefit youth and adolescent health. Set examples for others in your city, state, region, that it is possible to operate high quality healthcare while respecting the rights and needs of teen patients. I think so often we're directing people to these really excellent practices in the hopes that they will bring those practices to their own clinics and create those changes. Obviously, bring youth into the perspective in the conversation, and don't just do it once. Don't do it as a token. Create a structure that allows them to really partner with you to create change over time and in meaningful ways that would meet the needs of youth. Really, there's many different unique populations that we're working with. So how do you reach those unique populations? And it's something we're really dedicated to making possible, having youth consult and be involved in different ways. I mean, there's also partnering with advocacy organizations to pass legislation. It doesn't have to be you alone and your clinic alone. Like, who are those other advocates to help broadly expand and protect adolescent rights to healthcare? And then educating youth, really like showing them their voice and experiences matter, working with them to prevent some challenges if you can and where you can, and really start at that relationship level. So you can do your own advocacy and your own change in your practice that can impact, those different spheres of community and of policy and things like that. So, yeah.
Thank you so much, Erica. Dr. Laurel?
Oh, what a great question. So as both a healthcare provider and then now as a MPH student, I'm a first year student here, I'm trying to do that next step, because I've tried to, through my career, make changes within my institution. and try out new projects and pilots of interventions with stakeholders. We did have teen youth on our transition team. We did focus groups with youth, trying to have them involved. But that's, not everybody has to go and do their MPH, but that's probably one reason for me. It's like, what can we do? How can we talk the talk? How can we make our experiences in the trenches, so to say, in the clinics? How can we bring that to the next step? So looking at policy, and that's great that you say that we don't have to do it ourselves, but we could get more involved. Now, I can do that through my American Academy of Pediatrics. The Minnesota section is very involved down at the Capitol. We have Pediatrics Day, but that's one day. And so it's just, we all show up, but we really need to have that consistent policy going forward. And then just encouraging and modeling that in the clinic. So when I go back to work in January, it'll be, again, giving those kids that time and modeling that, challenging them to get ready for transitions, challenging them to make those decisions and know their rights. So.
Thank you so much, Laurel. Dr. Michelle?
Advocacy has been a huge part of my work in South Africa, and we've had to fight for a lot of our services. When I was a pediatric trainee, in the days before we had antiretroviral treatment in the country, we unfortunately had a president that was a bit of an AIDS denialist, and we had to fight for antiretroviral treatment. We had to fight for prevention of mother-to-child treatment. We went to court, and we had to, learn how to grow up very quickly. And the same is happening with palliative care, so I've actually worked my whole career in the NGO sector, where we basically raise funds to meet gaps in public health. And sometimes, you can kind of over-identify with your service. And I always quickly learned that, service without advocacy is not sustainable. So you can't just fill gaps and try and raise money to do that without actually advocating with the government. And I think what everybody has said is advocacy is not something that you do on your own. You really have to have a unified voice. So we have formed a lot of networks over the years, and those networks need to include the beneficiaries. So as a healthcare professional, you can't advocate for patients on their behalf, and we have to, let go of tokenistic kind of inclusion of the patient and the child. They actually have to be active advocates. We've had some amazing mothers, bereaved mothers who've come on board, come alongside us, and who better to advocate than people needing those services themselves. So we've had some really wonderful engagements with clinicians and families side by side. And it takes a lot of courage as well, and a lot of determination. We've been advocating for palliative care for the last 20 years. We've got a policy, we don't have implementation yet, the journey's not over. So it takes a lot of grit to actually continue to knock on those doors.
Thank you so much, Dr. Michelle. Dr. Laura, you wanted to say something?
I was just saying, wow, that's all.
Okay. Thank you so much, Dr. Michelle, for that. So we have one other question on our Q&A chart. So we have a question here for all our panelists. It says, often children with disabilities are faced with learning difficulties. How can healthcare practices and public health organizations collaborate with schools to ensure that these children get the educational supports they need for their mental, social, and emotional development? Does anyone want to go?
I will go first. One of my first questions when kids come in is like, after we say hello and all our pleasantries, is, how's school going? How's homework going? And whether or not that child has other chronic issues or they're relatively healthy, that's a key question on how the kid is doing. I once had a mom say, why are you asking about school? This is their checkup. And it's like, that tells me a lot. It's their day job. All my patients will know this. It's your day job. And so that's where I really focus in, number one, on how they're functioning in school with behavior issues, and that can go into learning issues. And we really need to be more aware of language processing issues. Many times we talk about ADHD and attention issues, but a lot of that is language. One of the first things we have to do in that evaluation of ADHD is to rule out language issues, not speech. Speech we can tell pretty, that's pretty clear in many times, but that language can sometimes be missed. And schools sometimes are not giving those services unless you're more than -2 standard deviations below the mean. Well, if you're not identifying it, or at -1.9 or 1.8, then you're not going to get those services. And so my understanding is if we are referring people for language, speech and language evaluations, and then do make a diagnosis of that, then the schools will provide services if you're at greater than -1 standard deviation. So within our schools, we need health and providers need to work with schools and being aware of these ways of screening and then providing services for those learning issues. Whether you have other chronic issues or everybody, it's like 4 to 7% of kids have these issues sometimes.
Does anybody else have something to add?
I'll say something. So one of the sort of policies in South Africa that came about a few decades ago really was about mainstreaming children with disabilities and not putting them in separate schools specifically for disabled children. But unfortunately, not all of the schools have really been disability friendly, from things like having, ramps and those kind of things. And also it requires quite a lot of working with a normally able child, so that you avoid things like teasing and that kind of stuff. And, I think we often focus on, making the environment suitable for the disabled child, but we don't actually, I think, put enough focus on actually empowering the other children to actually accept that child and to assist them. I find that children often tend to be on the two extremes. They might be extremely helpful, or they can actually be, very teasing and children can be mean and they can be very frank and open. So I think we actually need to have a lot more conversations with children about accepting children with different abilities.
Thank you so much, Dr. Michelle. Erica, do you have anything to add? Erica, do you have anything to add?
Yeah, sorry, internet cut out there for a second. I don't think much more than what Michelle was saying. I think a lot of it is finding, even in our own organization, we've partnered significantly with the Waisman Center, who works with Got Transition to do transition care. And it's been really valuable to see the spaces in which they're directly educating youth with disabilities and complex healthcare needs and their parents and guardians and providing them that structure, while at the same time urging us in the work we're doing to do better about integrating youth with disabilities and complex healthcare needs into our group of teens. And it's been really powerful to see these spaces where, regardless of ability status, we're saying, yeah, teens, come together, we're going to advocate together, we're going to meet you where you are. And it's hard, it's challenging, but I think those spaces where youth with disabilities and youth without disabilities, whether they're visible, invisible, chronic illness, whatever it is, has been really, really beneficial in moving systems forward. So yeah.
Thank you so much, Erica. Now we have a question here in the chat. It says, as public health and healthcare practitioners, do we have an obligation to report abuse and neglect? What does this process entail in your practice? Can Erica go?
Yeah, I mean, yes, I think we have that huge, and I'm not an active practitioner, so I'm not necessarily a mandated reporter, but my best interests of teens are at heart. And I think our biggest things when we work with young people is, when we work with providers who are working with young people, is to be really clear about when you do have to report, and really don't jump to reporting. So many teens feel like somebody reported in an instance that wasn't quite there when they could have maybe not had something escalate as quickly. And so I think just being aware of your own biases in what you consider that reportable offense. Self-harm is one that often comes to mind, as some teens have had reported, immediately told parents or guardians, I apologize for my pet. And others, you know, if they've worked through the teen to develop coping skills, they've not necessarily had to immediately report to a parent or guardian, but they've been able to work through that together. So I think just having an awareness, and don't automatically assuming mandated reporting is the thing that's going to help them. But of course, you know, make sure they're safe and healthy and in a good spot.
Okay, thank you so much, Erica. Dr. Michelle, do you have something to add?
So in South Africa, we actually are legally obliged to report suspected abuse. And if you don't, you can actually face, you know, being struck from the practice role for not reporting abuse. And unfortunately, there's a significant epidemic of abuse, you know, gender-based violence, child abuse. It's very rife in South Africa, especially, you know, in our impoverished communities. Yeah, and it's a big challenge.
Thank you so much, Dr. Michelle. Dr. Laurel, do you have anything to add?
I am a mandated reporter. I report when it's appropriate. I have learned through the years. I have called CPS, Child Protection Services, for guidance, and they're very good to guide me, yes or no. So I call sometimes if I'm concerned, and I get good guidance from my county child protection service social worker. So I'll leave it at that.
Wow, thank you. Okay.
I had no idea CPS could do that. That's really cool that that's a resource that you've used. I love that.
Yes. I call often. I have been educated by them over the years to know this, you know, this or that. Did that happen? Well, no, then it's not. They can guide you. So use them as a resource. Don't be afraid. If you call, I can call about concerns, and then they can let me, you know, they say, well, we won't do anything now, but it's good that it's there. So if someone else calls or has a concern, or yes, we've had other concerns, thank you for the information. So there's a connection and a communication there to be professional and appropriate.
Thank you so much, Dr. Laurel. I won't be afraid to call. Thank you, our wonderful panelists, Dr. Michelle, Erica, and Dr. Laura again. While you were talking, I was doing some reflections of self-reflection. And from today's discussion, I've learned that everyone's contribution counts. And, you know, it might be time, it might be resources, it might be services, as little as it may seem, you know, it can go a long way in touching the lives of our children and their families. When I reflect on how medicine has been practiced, I realized that there has been so more stereotyped approach. Healthcare practitioners and public health practitioners tend to, you know, give more of diagnostic approach to care rather than providing more of a holistic care and involving children and their families in decision-making about their health. You know, health to me means holistic care, like you all stated, physical, psychosocial, spiritual well-being, and using the rights-based approach to care for our children, especially those with long-term health conditions, you know, is crucial to addressing the social determinants of health. You know, our commitment to achieving child health equity will require prioritizing and addressing the needs of children using a rights-based approach in public health. It is a duty call for you and I and everybody and the entire community, as you all said, you know, to work together to prevent diseases, promote health, and sustain a good quality of life for our children and their families. Thank you so much. I will pass it on to Taylor.
Awesome. Thank you so much, everyone. That was so wonderful. We want to be mindful of everyone's time, so I will go ahead and close us out. If you have any questions or feedback, please send us an email at sphmchig@umn.edu, and that's in the chat. And if you wouldn't mind taking a brief survey, that's also been placed in the chat. We would love to know what you all thought of this event. This programming is led by the Maternal and Child Health Interest Group at the University of Minnesota, and you can check out our website at z.umn.edu/mchig. Thank you again, everyone, and we hope you all have a great rest of your week.